Good morning, everyone. I will be talking about approach to treatment of androgenetic alopecia in females. Now, hair is the richest ornament of women, as rightly said by Mr. Luther, and we would all agree on that. Hair loss for any woman can be a harrowing experience. It can be a leading sign of femininity that, when lost, can ruin a woman's self-esteem. So if you would ask me, I think the first and foremost step is to screen which woman you should take up as your patient and which woman you should refuse. You have to assess the mental status of your patient. If you find that the patient is depressed, suicidal, she has unrealistic expectations, she is over-anxious, unreasonable, she has a hobby of hopping from one doctor to another, it's a red flag, better to avoid such a patient. However, a woman with a smile is a welcome in the clinic as well as in life. A mentally stable woman patient who is positive, who is reasonable, and who is logical, it is safe to proceed and you can start with the management. As rightly said by one of the doctors right now, I strongly believe that every treatment, medical treatment in androgenetic alopecia in women is an illusion. Maybe you can say I'm biased being a hair transplant surgeon, but nothing works but hair transplant if the patient is agreeing to go ahead with the surgery. Now, the first step is to establish the correct diagnosis. Female pattern hair loss is simple to understand because when the patient comes to your clinic, you can see and say that she is a patient of AGA. We all know about the Ludwig's classifications, the Olson's classification, Christmas tree pattern, sparing of the frontal hairline, so that's not a rocket science. I'm not going more deeply into it. Theoretically, it is characterized by patterned hair loss with progressive shortening of anagen, progressive follicular miniaturization with conversion of terminal to vellus ratio to 4:1, which is generally about 7:1. Trichoscopy is a very important tool here. Now, an important thought that is women suffer patterned hair loss only in post-menopausal setting, which is a very common thought process. Well, the actual fact is a woman can lose hair prior to menopause without any underlying medical cause, simply affected by their genetic predisposition to it. Now, you have to choose the right candidate. Make sure it is female pattern hair loss, not any other active medical condition leading to continuous hair loss. So rule out any metabolic or underlying medical cause. So we all know that we have to get a hemoglobin, thyroid function test, we have to rule out PCOD, any androgen secreting tumor, drugs, any emotional, physical stress, history has to be taken properly. In case any underlying medical cause is identified, treat the cause, or better is to refer the patient. If no underlying medical disorder is there, if there is no underlying metabolic disorder identified, we can proceed with the medical management. Medical management, well, there are only 2 drugs which are FDA approved for management in women, which is minoxidil and, in women it is only minoxidil. Topical minoxidil is the only medication approved by the FDA. Now earlier 2% lotion was approved, but now since 2014, US FDA has approved 5% foam concentration of minoxidil to be used daily. Application, minoxidil should be applied as 1 ml of solution with a pipette or half a cup of foam to dry hair. After application, hands should be washed with warm water, and then follow-up should be done every 6 months. Finasteride in premenopausal women. Well, finasteride is absolutely contraindicated in premenopausal women. Women should not even handle crushed or broken finasteride tablets when they are pregnant or may potentially be pregnant. Coming to finasteride in postmenopausal women, it is not FDA approved. However, there are conflicting results in various studies. I prescribe finasteride in select postmenopausal women who desire more benefit than what minoxidil alone can provide and who have reported some moderate success in this added therapy. As there may be an association with breast cancer, personal or family history of breast cancer is a contraindication for off-label use of finasteride in women. Now coming to dual therapy in women. Minoxidil in women, though it is not approved, but yes, we can try because there are some good results with this. Anti-androgen therapy, when there is an androgenic cause which have been established, if it has been established, can be tried. Minoxidil with spironolactone or minoxidil with cyproterone acetate. Now, spironolactone is a potassium sparing diuretic. 50 to 100 milligrams for early cases can be given, and 150 to 200 milligrams daily for moderate to advanced cases can be given. We have to monitor the sodium, potassium level, KFT. Patients should not be on ACE inhibitors. These are all things we all know. Minoxidil, now in post-menopausal women, the dosage can range from 2.5 to 5 milligrams, more commonly 5 milligrams. This can be tried in post-menopausal women. Now, other medical modalities are cyclical therapy, which I strongly advocate and give my patients, and 95% patients respond to it. Bimetoprost, which is FDA approved for eyelash hypertrichosis, it is a prostaglandin analog, low-level laser therapy, and PRP therapy. In short, about cyclical therapy, cyclical therapy basically is giving various nutrients in a cyclical manner spread all over the week. So nutritional supplements are considered harmless and consumed without thinking of interaction or overdose. How high dosage of one nutrient can affect the absorption and efficacy of others. Example, administered together, vitamin C can destroy vitamin B12 and iron and calcium can reduce the absorption of one another. So to utilize nutrients without interaction and overdosage, cyclical therapy makes the use of different synergistic nutrients on different days of the week, repeating in a 3-day cycle. Low laser labor therapy, caps and combs can be given. It should be given thrice weekly for 30 minutes. Principle is photostimulation of hair follicles by cold laser light. PRP therapy, well, at present there is no standard treatment protocol for PRP injections for hair loss. Though it is an effective way, in our clinical practice we do see some improvement. Now, if the after initiating the medical management, if there is an improvement in 6 months, one can continue the treatment or consider a hair transplant. If there is no improvement, then definitely go ahead with hair transplant. Common areas of concern when a patient comes with AGA is hairline, midline, frontotemporal area, part line. I'm just not going into details. Well, you have to identify the most prominent area which is visible to your naked eyes when a patient comes to you, because it's a diffuse involvement. We can't cover the whole area. You have to mark the area. You have to extract from the donor, which is the occipital area, implant, and these are some of the results. This is before and after. Before and after.
Thank you, Dr. Shalini. Any questions?
Excellent presentation, Dr. Shalini. I just wanted to ask here, in scarring alopecia, in primary scarring alopecia, as all of us know, we wait for the stability before we take the patient for the hair transplant. How about PCOD? If a patient of PCOD is there, want to go for a hair transplant, would you wait for the stability or you would go straight away? And if yes, then what are the criteria you will be using to determine whether the PCOD is stable or not?
See, if a patient of PCOD comes to me, I get her investigated, I refer the patient to a gynecologist. Once she is stable, she is under control, then I may plan to take her up.
Any specific investigation would you like to go for?
I rely mostly on ultrasound, bilateral ovary. That's the most reliable investigation. Hormonal investigations are also there.
Okay, thank you.
By handling a crush tablet of Finasteride by a pregnant lady, what doses she has to crush to get a side effect? How do you decide that?
A pregnant lady, even if she touches the Finasteride, the crush tablet of Finasteride, I don't know about the exact dosage, but yeah, even if she touches, it's written, feminization can occur.
Okay, thank you.
You spoke of childbearing age group, but if the family is complete and they have undergone sterilization, you said it is a big no, why should not be there? If a lady, his family is complete, why can't we give them?
Yeah.
We can do anything according to our discretion, but as per FDA, we should not prescribe.
Not that. It makes a common sense. They have undergone sterilization. She is in the childbearing age group. Why should we not give?
So if the family is complete, she is not planning another baby, then we can try. Why not?
Sir, may I make a submission there? Finasteride in female pattern alopecia has not been shown to have as much effect as it has been shown to have in male androgenetic alopecia. Probably in females, the 5-DHT pathway is not as, important as it is in males. So finasteride might not be as important.
Yeah, it's because of aromatism. See, you insisted that we should use aldosterone in all the patients of female pattern hair loss.
No, sir, we should not use in all the patients. We can try.
If there is a evidence that there is testosterone increase, then only we should use it. It is not the first line of treatment
is not.
in androgenetic alopecia.
Yes, sir, it is.
Anil, the only thing, Anil, you said that finasteride doesn't work. It's in higher doses that it works.
Sir, even in higher doses, they say
When
that
if at all it has to
5
work,
DHT
it would
yeah.
work in somewhere to the tune of about 4 to 5.
Yeah, but the evidence for finasteride in male pattern baldness is
Yeah,
much
sure.
more.
I'd
than
agree with
in
that.
whatever
But if
dose.
at all it works in female pattern, it's in much higher dosages. That's the only thing.
Dr. Shalini, ever since we started using dermoscopes, we have realized that diffuse occipital involvement, especially in women, seems to be the rule rather than the exception. So would you say that a hair transplant is less permanent in women than in men? And what happens when somebody has DUPA and then they stop minoxidil? Because eventually, someday most people stop, at least for a bit.
Well, DUPA is a very interesting thing. It is diffuse unpatterned alopecia, which is emerging nowadays. We can see more and more cases. In that, the donor area is also involved. Well, we should not take up such a patient for hair transplant.
So you would say that's a strict no-no?
Yes, it's a strict no, and in such a patient, one should suggest maybe a wig or cosmetic camouflage or any other modality which is non-surgical. Even medicines, I don't think have much of a effect. It's a bad prognosis.
But wouldn't that rule out too many of these women? So the number of women who are eligible for HT would be much less than...
Yes, definitely. DUPA, because the donor area is not there to extract. So we cannot proceed ahead with the HT.
Dr. Shalini. Thank you very much.